Okay. So today I have the pleasure of having Dr. Dennis Hand come and present to us for our journal club for June. I'll put his bio in the chat, but I'll let you kind of self-introduce and kind of get things started. Please feel free during his presentation today if you have any questions, any comments, please put them in the chat. I'll be moderating that, and we will have dedicated time for Q&A at the end. So I'll hand it over to you, Dennis. Thank you again.
Awesome. Thanks, Caitlin. Really honored to be presenting here today. Uh, let's see, I'm going to share my screen and I'm going to share these slides. And we're going to use that thing. There we go. There, now you don't see my notes, which
Yes,
don't exist anyway.
you're good.
Awesome. So thanks. So today I'm going to be talking about topic methadone dosing in pregnancy, what we know, what we've ignored, and what we still don't know. Um, my name is Dennis Hand. I am an associate professor in the College of Nursing at Thomas Jefferson University. I'm also executive director of the Jefferson Center for Maternal Addiction Treatment, Education, and Research. We have a long history here in Philadelphia. We were started by Loretta Finnegan a little over 50 years ago. And we have some clinical programs that are directed by my colleague, Kimberly McLaughlin. And I run a lot of the research and education and community partnership work. I'm a psychologist, a behavioral pharmacology background, so I'm not a nurse, and I've been studying this topic for about we're getting up on 15 plus years now. Kayla and I were young and getting into this together quite a long time ago. So why don't we go ahead and jump in? So, an outline of what I'm going to talk about today. If you'll indulge me, I'm kind of a history buff, and if you've seen some of my talks before, you've seen some of these slides around history of opioid use in the United States. I'll try to keep that to under 10 minutes just to orient ourselves and remember the past. We're going to talk a little bit about what we know. And I'm going to sort of undersell what we know because we know a little bit more, or quite a lot more, actually. I just don't have time to get into all of it. But the things that are pertinent today, we'll talk about that, methadone is an effective medication for opioid use disorder. We're going to talk about what we know about pharmacokinetics and pharmacogenomics. It's going to be really light. We're not going to dig too heavy into it, and hopefully it'll be approachable to a broad audience. We'll talk about some things we know about how it can affect fetal neurobehavior and how dosing strategies can affect that. And we'll also know some things about racial inequities that actually we're going to touch on in the history. Then we're going to talk about what we've ignored, which is a lot of what we've learned in science. We've ignored a lot of it in research practice or in clinical practice, I believe, and also in research. And there's a whole lot we still don't know, and it's still a very important area for us to be doing research in. Uh, so over here, oh, I have animation. So history of opium products in the United States, just going back to the 1800s. Everyone, I think, is probably familiar with the fact you used to be able to buy this out of catalogs. Laudanum, paregoric, these are tinctures of opium in a very high ethanol concentration. Um, Sorry, just moving the chat over here so I can see any questions. Uh, uh, this was available in catalogs and often recommended for conditions that aren't real, maybe we thought were real at the time, and very often given to women for things like hysterical pregnancy and other maladies that really don't exist. We also had laudanum for baby too. As we know, opium is a pretty decent cough suppressant, and if it helps with colic and other things, and it was also sold for infants as well. We've known that people who use consciousness altering substances can often develop substance use disorders, as we call them now. This is from the Boston Medical and Surgical Journal from 1833, talking about opium eating, that, hey, some people do become dependent and develop substance use disorders, and a lot of them, as they found, would like to stop using opium products. We've known this at least since the 1800s. Honestly, the history of drug use goes back thousands and thousands of years before the current era, even. But we've known about this in this we'll call it modern time, here published in the precursor to, I think, the New England Journal of Medicine in 1833. We've also known quite a bit about opium use during pregnancy and its effects on infants and neonates. This is from 1881. This chapter describes Mrs. E.F. and G, who was 42 years old, who had neuralgia, chronic pain, and was taking opium, taking laudanum on the regular. And she had previously had a pregnancy with this physician, and we'll talk about that. Actually, I don't have those in here. That baby was born, developed the signs, as we would call now, of neonatal opioid withdrawal syndrome and neonatal abstinence syndrome, and stopped eating, failed to thrive, and died. When they came into this physician's care, similar things started to happen. The baby was born, the baby being bright and vigorous, took to the bottle readily, but in 2 or 3 hours after delivery, the mother observed the same symptoms that preceded the death of her last child, called the doctor's attention. The baby was cold, clammy, crying feebly and low, and the physician was naturally surprised at so sudden a change, but had no idea why. The symptoms got worse, and the mother, in an agony of fear, comprehended, as by an inspiration, the true condition of her babe. The cause and effect presented themselves. The babe had imbibed in her blood, impregnated as it was by morphia. She had been taking opium products, and the baby had been exposed and was having the same physiological dependence as she had. So she made up her mind, and again, this is 1881, to purchase her babe's life at the expense of its being an opium eater, and sent the nurse for laudanum. And then she dosed her infant with laudanum. She provided pharmacotherapy for neonatal opium withdrawal syndrome herself. And the baby started eating again, lost all those signs and symptoms of withdrawal, and thrived and lived on. They did not, however, figure out that they could titrate this down, and the child was still taking opium at 7 years old. So a little bit to learn. But mom figured this out. Mom figured out what was happening. She knew her body and she knew her baby and she trusted herself. And I think that's a thread for a lot of us here. We agree with this. So by the end of the 1800s and through the 1970s, so that's almost 200 years, right? By the end of the 1800s, about 1 in 200 Americans were using opium products, and about 60% were white and female. And as a result, the medical community started to reduce the reliance on opium products. We had the invention of aspirin, we had germ theory, we had some other medical innovations come around, but we generally said, hey, we need to stop recommending opium products to patients. Okay. So they said, hey, we should down titrate the doses that people are taking for a long period of time with chronic use. And you know what? Actually, if we maintain people on therapeutic levels of opium products, they thrive. And this is a medical approach. Sounds very similar. And it was effective. It was highly effective. However, with the Harrison Narcotics Tax Act in 1914, which really put the kibosh on a lot of the free sale of opium products and cannabis and other things. It also, by 1917, had made illegal the prescription of opium products for use disorders. And so physicians were barred from using this. And the last program, I believe, closed in 1917. I think it was in Louisiana. And that remained illegal into the early 1970s. And as we all know, in the 1970s, when methadone was studied by Vincent Dole, Mary Jean Krieg, Janet Nicewander in New York City, methadone as a treatment for opioid use disorder came about. And it came about after this very long period of this being illegal. And even during its development was highly controversial on the judicial side and some law enforcement sides. And as a result, we wound up with methadone as a treatment for opioid use disorder within a programmatic setting, but very tight regulations about its use, which I'm sure everyone is pretty familiar with. That's kind of the backdrop of how we got to where we are today. Over this time, what do we know? And like I said at the start, we know an awful lot, and I don't mean to downplay that or misrepresent. We actually know an awful lot. We all know an awful lot about methadone and pregnancy. This chapter here was an United Research monograph written by Lord Finnegan in 1983, which was the year I was born, so 43 years ago. Clinical and perinatal development effects of methadone. And if you've never read this before, it's on Google Books. I have a copy here in my office. It was probably Loretta's personal copy. Very comprehensive information about studies through from the 60s, 70s, and 80s on what we knew then about methadone and pregnancy and its effects on a whole bunch of body systems and development even back then. We know that it's an effective medication for opioid use disorder, and also other programmatic elements are incredibly important. It is an effective medication, and people have great success, including in pregnancy, when it is used. We also know some things around dosing. We know that higher doses are generally better. This study down here by Christine Wilder uh, 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 was one of many studies that showed even in pregnancy that 60 milligrams a day of methadone and above is associated with greater treatment retention, less likelihood of return to use. And we've seen that in other populations as well. Actually, that dose is a little bit higher, maybe 80 or getting closer to 100, depending on World Health Organization or not. Some things we're not maybe quite so sure about is dose and neonatal withdrawal associations, dose effect relationships. That gets a little bit hazy. We know that buprenorphine is at least non-inferior to methadone. We know that some of the injectables are superior to both sublingual buprenorphine and with some outcomes. There's a lot more that we actually do know. But what I really want to talk about today is some of the stuff that we know that really hasn't borne out in clinical practice that we need to learn more about, and maybe we need to also do a little bit more of. We need to be more careful when we talk about it. So, hey, we know methadone is a full mu opioid agonist. It's also important to remember that it's also an NMDA antagonist and a human ether agogo gene potassium channel inhibitor in the heart. All right. So the methadone that we use in the United States and a lot of countries in the world is actually a combination of two enantiomers of methadone, R and S methadone. R methadone is the mu agonist, right? This is the one that's providing a lot of the treatment effect with regard to opioid use disorder. S methadone is not a mu agonist. It's the NMDA antagonist, which may help with some of the neuropathic pain that control that you get with methadone. And also that's the one that's the hERG potassium channel inhibitor, which contributes to prolonged QT intervals, which increases risk of fatal arrhythmias. But that's what we use in this country as a mixture. We'll come back to that later. We know methadone prevents withdrawal and cravings. It blocks additional opioid effects when titrated appropriately. And generally speaking, the pharmacokinetics support single daily dosing for a lot of folks. The half-life is roughly 24 hours. But as we've learned, there's huge inter-individual variability, and pregnancy contributes to a lot of this as well. So we know about methadone pharmacokinetics and its variability. This is from 1985, Susan Pond, Mary Jean Creek, and a handful of others, Neil Benowitz, of course. And these are data from a couple of pregnant people. I know it's a little small and hard to see. It's hard to see in the journal itself too. But basically, these filled square and open squares and circles down here are during pregnancy. And this is over the course of hours, from 0 to 24 hours on the side-to-side axis, and the up-down axis is plasma methadone concentration. As we see a rise to the peak within the first hour or so. But we see that during pregnancy, plasma methadone levels fall off very quickly, and by 24 hours, we're down to about 40 nanograms. We're about, doing the math in my head here, about 20% of what they were at peak. These diamonds and triangles, however, are postpartum, 6 to 12 weeks postpartum, I believe, 9 weeks postpartum. And we see that at 24 hours, the plasma methadone level is about half of its peak, right? So we see during pregnancy, people are metabolizing and clearing more of that methadone out of their plasma in 24 hours than they are postpartum, right? So pregnancy is enhancing metabolism and clearance. I mentioned that variability here. Another way to look at methadone metabolism has been really pioneered by Jack McCarthy. who I don't think could make it today, but he's going to watch the video. So hi, Jack. Um, uh, Using the methadone to metabolite ratio, methadone metabolism is relatively straightforward. It's simple enough I can understand it. Methadone is metabolized by liver enzymes into its pretty much inactive metabolite. We'll call it EDDP. And the ratio of methadone to EDDP uh, is a measure of a person's metabolic rate, essentially. And Jack's been working on this with some other folks for quite a while. This colorful graph here is a several hundred, if not a thousand or two samples from non-pregnant, not necessarily pregnant folks who had samples, blood samples sent to this lab in California. And this is the expanse of the inter-individual variability of methadone metabolism that's measured by the methadone metabolite ratio. See, people here in this, most people are here in this peak, which roughly correlates to 24 hours. But as you can see, a large number of people have especially higher ratios, and a higher ratio is slow and intermediate metabolism, meaning maybe that half-life is a bit longer than 24 hours. And then where we're looking at in pregnancy are these short, ultra-rapid metabolizers on the left side of this graph, right? People who are chewing through methadone so quick, that denominator of the methadone over metabolite ratio is getting really huge, so the ratio is getting smaller. In the context of pregnancy, Jack published this in 2018. We see in the first trimester, this ratio of methadone to its metabolite, I believe this is at trough, is about 7.2. By the second trimester, that falls to about 5. So it goes down by about 40%. That is an increase in methadone metabolism. And then by postpartum, I think this was 6 weeks postpartum, it's right back up to where it was in the first trimester, right? So it rebounds quite quickly after pregnancy. We've recently replicated these findings much earlier. This is a very busy graph. I'll explain this. These are samples taken from about 40 pregnant women who are undergoing inpatient methadone initiation at our hospital here. And this is a population PK-based study. The blue line, or the line that's going up more quickly, these are people in their first trimester as a function of dose, and this is on the y up-down axis is the methadone metabolite ratio, and these lower lines are second and third trimester, people who are initiating methadone in the second and third trimester. Basically, we showed that by the second or third day that a person is taking methadone, we can detect this methadone metabolite ratio, and it maps on to a lot of what Jack had found before. And this is a graph that sort of summarizes that. On average, in the first trimester, people are showing about a 7 ratio of methadone to its metabolite of about 7. And then by the second and third trimester, it's down around 5. And this is very early in treatment, and it's correlated with the trimester of pregnancy. And we can measure that right away. These are very small amounts of methadone in the serum, but it's possible. We know a lot about the pharmacogenomics of methadone. I'm not going to dive into this. We know lots of different polymorphisms and whatnot that affect the production of different CYP enzymes and opioid receptors and whatnot. These all play a role. We're not going to dig into those, but there's quite a lot of literature on this. Why does this increase in metabolism happen? We do know during pregnancy, pregnancy hormones induce the genes that code for the enzymes that metabolize methadone and many other drugs, specifically 3A4, 2B6, 2D6, and a host of others. We also have increased cardiac output, blood volume, fat volume, renal clearance during pregnancy. So we have more metabolism, more clearance of methadone during pregnancy, and that's what's driving this more rapid metabolism. We're also learning, I think Vani is here, I don't know if Vani is here or not, how to start people onto split doses of methadone, right? So when you have an enhanced metabolic state, we need to start providing methadone more than once a day. And that's really what we're going to talk about today. Are we providing methadone more than once a day, and what do we need to know about that? And we're just starting to learn this right now. And Vania did this relatively small study. It came out late last year. Feasibility of an inpatient split dose rapid methadone induction protocol for pregnant individuals. She's been doing this clinically for a very long time, and it's really great to see these data. But basically, it was feasible to start people taking methadone inpatient directly onto a split dose. This is the chart from that publication that basically by day 2, giving 2 doses of methadone a day, along with some as needed doses based on withdrawal signs. And by day 5, getting up to a daily minimum dose of 100 milligrams a day. Remembering back, that's like the minimally effective dose that is associated with greater treatment retention, right? And this basically breaks down to 250 milligram doses a day. Here's on the graph here to the right is sort of a cascade of care of the 14 people who were started on this. They were all linked to an OTP. We get a lot of questions about that. Will OTPs accept people on split doses? And by and large, yes, they are. Vania's done a ton of work to make this possible in Washington. And hopefully it's going to catch on in more places. And then we see a few fewer people attend the OTP intake appointment. And then by 30 days post-discharge, a little more than half are still taking methadone. So I think there's still some things to learn here, but it's feasible and acceptable and it's possible. And here's a way to do it. We also know that dividing methadone into 2 or more, at least 2 doses a day, during pregnancy, can be less disruptive of fetal measures. So we know that methadone slows down fetal movements, it slows down fetal heart rates and whatnot. But this study by Lauren Jansen, which was an experimental study, they took pregnant women and gave them, they were sort of randomly assigned to start on a split dose, they were already on methadone, started on a split dose and had these measures taken, and then did a crossover to a single dose or vice versa. And basically found that during split dose conditions, there was less disruption of fetal heart rates, fetal heart rate variability, and motor activity. It still suppressed some of this activity, but during split dosing, it was less so. So it seems to be a bit better for babies' neurobehavior signs than single dosing is. And, we've known this for a long time. I started talking about stuff from the 80s and all that stuff that Loretta Finnegan had written about in those early works. We've known that pregnancy enhances methadone metabolism since at least 1985 in that Pond et al. Study I showed. But it's been very difficult to do within the regulatory framework. And if you know anything about OTP regulations in this country, it can be pretty daunting and variable by state to state. Not to let a pandemic go to waste, the pandemic provided a natural experiment to start doing more of this, right? Split dosing is going to probably require people to take at least 1 dose home a day. And we're giving a lot more take-home doses of methadone during the pandemic, and we found it worked pretty darn well. It's sort of infeasible to ask someone to come back later in the day for a second dose. It's not impossible, but it's a little less feasible. But hey, in 2022, SAMHSA wrote to the state opioid treatment authorities and said, hey, split dosing is a thing, and you can use these tech-home flexibilities to allow it. Please don't be a barrier to letting this happen, because we know that it's going to be helpful for people. And a lot of folks maybe agreed with that, but it took some nudging. There's 50 different state opioid treatment authorities, and even to this day, as we'll see in a minute, they're not all on the same page. And this was codified finally in the big regulatory revamp in 2024 that say, hey, split dosing is a thing that should be considered during pregnancy, and there's benefits that outweigh the risks, of course, and weigh those clinically. But basically, we should be doing this. But it took a really long time, almost 40 years, from really knowing that was a thing to the regulations relaxing a bit and saying, hey, we should be doing this. But now getting to maybe the stuff that we've ignored. We've known this for a long time. There have been pathways to doing split dosing during pregnancy. Obviously, we needed to say something about it to facilitate it in 2022. So who's actually doing it? And so we're just wrapping up a study here. I presented this at the College on Problems of Drug Dependence a couple of weeks ago in Portland. We recruited staff, a lot of people from the WAG listserv joined, and they were at 22 different opioid treatment programs across 13 states, from east to west coast. We spanned the entire country. And this was done between 2025 and 2026. And we found that of these programs, about half, a little less than half, 43%, just do not provide split dosing of methadone to pregnant women. And they don't, if they did this, they don't provide split dosing to anybody for any reason. And the reasons that they were given kind of ranged, and it was something of a small sample size with only 22 OTPs, but there were staff concerns around safety, diversion risks, and potential liability of that. And then state opioid treatment authority issues were another barrier that was coming up, and also medical director concerns. Some medical directors were not comfortable with split dosing in general. We've had this long history, right? I gave that roughly 8-minute history of how we got to where we are from the 1800s to today. Methadone as a treatment for opioid use disorder came about in an era of heightened criminalization, discrimination, and this really built barriers that we have to overcome to do something as basic as dosing to meet someone's physiology. We got here a lot more quickly with buprenorphine, right? It's a newer drug. Very similar studies were done, and we jumped right to divided dosing there during pregnancy very, very quickly. Again, it's in a different regulatory framework, in a different time, in a different era, but this could be possible with methadone, but we still have a lot to learn. Another question that came up is, are we ignoring what patients think, right? We need to take the patient's feedback and opinions into account when we make these changes. As we saw, mom knows best. In 1881, mom had already figured out how to take care of her own infant who had opioid withdrawal. We surveyed 59 folks in our clinical program here who took methadone during pregnancy, and we found that only 4 of them, or 7%, had received a split dose of methadone in pregnancy. Honestly, when I got here a little over 11, 12 years ago, I believe the policy said we don't do split doses. And honestly, we had great treatment outcomes, right? It was fine, but it's a newer thing for us to do. 67% said medical staff had talked to them about methadone and pregnancy, which means a third never got a conversation with a medical provider at any time point about how methadone and pregnancy interact. 12% said absolutely no one talked about it. So we have counselors and recovery specialists and maybe peers who talk to them about that. They did pretty well on some knowledge questions. Again, they know their bodies pretty well. So about half knew that a pregnant person metabolizes methadone more quickly, but about half thought that taking a higher dose of methadone would address this. So there's a bit of a knowledge gap right there. When we asked them about, hey, should split doses during pregnancy be a right or a privilege, the majority of folks, almost 3/4, said, it's a right. We need to be dosed based on my medical need and not my treatment compliance. Because sometimes my medical need will help my treatment compliance, right? Interestingly, though, about 2/3, less than 2/3, thought take-home doses were not a diversion risk. So they had some concerns about their ability to maintain a take-home dose of methadone that early. We know a lot of folks, at least in our program, who are pregnant are starting a treatment episode during that pregnancy. And so they're often very early in their recovery journey, that segment of the recovery journey. And they had some concerns about that. Over 1/4 thought they would be a target for violence or theft because they had that take-home dose of methadone. And still, over 3/4 said, I'm confident in asking a medical professional to evaluate me for a split dose of methadone. So we have some things that we need to consider here. This was led by medical student Elaine Chen. We also may be ignoring a longstanding racial inequity in methadone and medications for OUD. So this is a study by Davida Schiff that came out a few years ago, showing that during pregnancy, non-Hispanic Black and Hispanic women were significantly less likely to take medications for opioid use disorder in the year prior to a delivery, especially young women. The effect sort of starts to go away with age, perhaps, with older women being a little bit more likely to take medications for OUD across races. We've also found this racial inequity in methadone dose within our population. This is Emily Rosenthal was a maternal fetal medicine fellow here. This was her fellowship project almost 5 years ago now, that we found that women of color, which was predominantly Black, non-Hispanic women here, were getting about 63% the dose of methadone than white women were at delivery. This is a sample of about 350 roughly women. We've recently replicated this with a brand new cohort, and we find that this inequity emerges during that inpatient initiation. We use a similar thing to what Vania's paper was about, but we don't do initiation on the split dosing. But we found that the inequity actually emerges there in cows-driven dosing. Hopefully that'll be out in the next few months and publish that. This is not new. We've known about this racial difference in methadone doses since the 80s. Harold Pollack at University of Chicago has been studying this for a very long time and has consistently found that methadone programs in predominantly Black areas are significantly more likely to use subtherapeutic doses of methadone, below that 80 milligrams of methadone level that is commonly referred to as a therapeutic dose. There were analyses of clinical trials network data with methadone and buprenorphine and found that for both medications, Black participants, A, were underrepresented in those studies, and B, got significantly lower doses of both medications. I haven't seen a lot of work to evaluate does that have outcome effects? What's driving that? Is there a way to ameliorate those differences or not? So we may be ignoring this again for almost 50 years. So taking what we've ignored into what we still don't know, a handful of us here on this call did a systematic review of split methadone dosing during pregnancy. This came out in 2025. Nigat Khan was the lead author on this, and Andre Jones was her partner in that. And we found only 8 studies that were examining split methadone dosing during pregnancy. 8 studies in the history of all of this looked at split dosing. There were almost no comparisons between split and single dose methadone in there. The only one was that Janssen study, Lauren Janssen study I talked about earlier. That wasn't even a pregnancy outcome. That was intra-pregnancy fetal neurobehavior. There are a lot of studies, single-arm studies. Jack McCarthy published a lot of them, showing really great clinical outcomes, low rates of neonatal withdrawal, great retention, low use at delivery, good satisfaction. But a comparison to a single dose was never really there. It just showed it was at least on par, maybe better than with global standards. So we just don't know. And often dosing regimens are unreported in most studies, including the studies that compare buprenorphine and methadone. So, we've seen a lot of studies come out showing that buprenorphine might be associated with better neonatal outcomes than methadone, but again, we don't know how it's really being used in both. And I think we should look a little bit more into that for a host of reasons. So that leads to a large number of questions that remain, like, how do I divide the dose? In Vania's study, it went straight to half the dose in the morning, half the dose in the evening, and you might be able to clarify if we deviated from that. But basically, is there something we can learn about how to divide that up? Our patients are often on not half and half in our program. They might be taking a little bit more in the morning, a little less in the evening, some the opposite. What do we do after pregnancy? Right? If we're going to split a dose during pregnancy because metabolism is elevated, do we combine doses after delivery? Is there a destabilization there? Do we continue? How do we do this? Like, what's the right thing? We need to be talking with mom. We need to be coming at this together, but there's very little data about what to do. Does area under the curve of exposure increase with split dosing? So, I was talking about how we don't really report the dosing regimens. If those studies comparing buprenorphine to methadone were just single-dosed methadone, those infants may be exposed to less methadone than infants would be if they're on split dosing, right? Because if you're metabolizing and clearing it, you're going through cycles of I'll say satiation and withdrawal daily, which can be very stressful, but it's less total exposure. So we have some questions about that, or maybe the reduced stress could result in better fetal and neonatal outcomes. We just don't know. Um, what are patients already doing? This is a study I love to do with patients who take homes. What do you actually do with your dose? I mean, I learned when I was a postdoc before divided dosing of buprenorphine was a thing. Research participants were telling me that they're taking some of their tabs in the morning and some of them in the afternoon. Um, and then the studies came out. I wonder what patients are actually doing. And I think getting a natural history could be very, very informative. Again, remember, in the 1800s, mom figured this out for herself. Um, uh, how does dosing regimen affect breast milk concentrations? Is there any change here? What does split dosing do to that? Um, what about using R-methadone instead of the racemic mixture of methadone, right? There's some countries that do that in Europe. R-methadone is not approved in the United States by the FDA, but you know what? We know it helps people who have prolonged QT intervals. If you just give the R-methadone, it reduces the QT interval, so less chance of dangerous arrhythmias. Um, it could be a beneficial thing here with fewer side effects. We honestly should be exploring this. How does the racial inequity emerge? Really, why does it emerge? What does it mean? What should we do to ameliorate this? This is really important stuff because we know that, I mean, there's data that show that women of color are more likely, if they receive medications for opioid use disorder in pregnancy, are more likely to receive methadone than buprenorphine. And if they're getting sub-therapeutic levels of methadone, it's sort of compounding even more issues there. So what are the impacts of this racial inequity? These are the kinds of questions that I stay up at night thinking about and try to find grant writing mechanisms for. But I invite other people to think about more questions or even take on some of these as well, because it's an effective treatment for opioid use disorder. I think maybe, we've been ignoring some of the data for a long time clinically, and also in a research context. We have a lot to learn. We have so many medications for opioid use disorder and so many formulations. This could continue to be an effective intervention. Uh, Here's some references. Here's my information. There's my LinkedIn if you want to stay up to date with our center's stuff. We have a monthly research seminar that Madison is going to be presenting at tomorrow, and study updates and be connected. Happy to have a discussion, answer any questions.
Thank you so much, Dennis. That was great. I love the historical context and bringing us through to the present. If anyone has any questions, please put them in the chat, or you can raise your hand, your Zoom hand. I'd be happy to call on you for us to have a discussion about. Loretta, you're up first.
First of all, I just wanted to say to Dennis that that was a wonderful presentation, and it brought back so many memories for me because I prescribed my first dose of methadone to a pregnant woman in the early 1970s, and there was a cigarette commercial that said, we've gone a long way, baby." And I must say, thinking about what we did in the 1970s, even with the wonderful research of Dole and Niswander, uh, there was so little known about pregnancy and so many prejudices about treating pregnant women with any medication. So this was a terrific presentation, and I thank you for it.
Thank you, Loretta.
Thank you, Loretta. We always appreciate hearing from you. Colin, you have your hand raised.
Yeah, thank you for that presentation. Dennis, I missed the first part of it, but really glad I got to join the second half. I'm one of the family medicine, addiction medicine doctors at Swedish in Seattle. And one of the things that's come up more recently for us regionally is postpartum oversedation on methadone and bad outcomes for newborns. There are programs in our state called Pregnant and Parenting Women's or PPW programs that are like 6-month residential. Often patients will leave our, intensive inpatient program to go to those 6-month residential, and they can have their babies there with them. And the PPWs are reporting high frequency of birthing parents who are having trouble staying awake holding their baby. I think there was one death from co-sleeping that was at least partially attributed to that. I'm aware of 2 of our patients who discharged to one and dropped their babies and had intracranial bleeds. And both of those patients were very clear, like this was methadone. And at the same time, we're really focused on, believing our patients and trusting them about their symptoms that they're having. It's just hard to square with like when they're in our groups and they're falling asleep during the group, but then I see them later and they're telling me and they've got objective signs of withdrawal. And we're doing split dosing, but most of these cases over station are postpartum. Some of them are antepartum, and so just I think we're going to have bigger conversations regionally. But think about how do you all manage postpartum changes in methadone metabolism and dose modification considerations with that? Any tips or tricks you have in like kind of communicate with patients so they feel empowered to be kind of part of that process? Is there could be a lot of stigma as well, like your methadone dose is too high. I feel like they're feeling judged when I have to bring that up. And yeah, thank
Yeah.
you.
Yeah, we deal with very similar things, and thank you for that, Colin, and for highlighting that. We have a residential treatment program here, so very similar. We often discharge newborns home into that setting, and on one hand, um, it can really help with closer monitoring and witnessing these things and having these conversations. But it's incredibly complicated because we have methadone, we have the changes in metabolism, we have a dynamic situation, we have maternal stress. We also have other medications that are having interactions, right? A lot of psychiatric medications, we see a lot of that here. We probably do as well, that interact. And like you said, there's stigmatization, and the methadone is the first thing people point to. And it's really, we found a comprehensive approach. Now, we used to do a rote, everyone goes down by a certain amount. It was honestly a trivial amount of methadone. Um, and then there was some data that were published that said, hey, a lot of people end up going right back up later. So we take a symptom-based approach now. But, very, very close monitoring. It still does happen. And it's sort of managed by our nurse practitioner team and our psychiatrists in a, a, a very t close way, but we don't have a lot of data on how to handle it. We need to be talking about that more. I think that would help a lot, and maybe some of the physiological information could come, but then also talking with mom and setting the expectation ahead of time. That's another thing we've started doing. Say, hey, this is going to change. Your body's going to change. Duh, right? You know this. Your body's changing now. It's going to change again. And it's not just all over with that 6-week postpartum visit. And I think that's another consideration there that, for a lot of moms, their care, that medical care that's directed at moms ends around that point, and it's all focused on baby. So keeping that cohesive uh, team together. So one thing that we do is we do group well child care. And it's not just for mom, it's the dyad, and we're talking about all the things. The kid's sort of the focus, but also how do you work with the kid and whatnot. And it kind of keeps the comprehensive team together.
Anyone else have any questions for Dennis or any other comments for discussion? Oh, hi, Lauren.
Hi, Caitlin and everybody. Thanks so much for your talk and work, Dennis. I am in Minneapolis, and even though I have a methadone clinic associated with my hospital, I feel like every Fania, every methadone talk I come to, I have the same questions. I'm really struggling that even when we do inpatient starts of methadone, to have my methadone clinic continue the same dose with this worry of dose stacking. And I wonder, and so like because I'm really leaning in with the research that you all are producing and like how we can do these faster initiations. We can get people to more comfortable doses like within 3 days. But my methadone clinics are reducing the dose when the patient comes outpatient. And so I'm just wondering if there is much data about dose stacking in pregnancy. And I mean, and part of what we don't have is close monitoring after discharge from the hospital. There are only a handful of treatment programs that I'm getting folks into in Minnesota. And so I don't have like a secure, safe discharge place. So love to get some insights about that. And if there's some real data, I can continue to push in front of my colleagues to make some cultural change.
Vanya, maybe you have some more information about that.
Yeah, sure. Maybe all of us can try to answer Lauren, and I'd like to start with expressing gratitude to Dennis for this talk, and also having Loretta, who has been a mentor for all of us and trailblazing methadone treatment. Loretta, you being here at this age just shows us how much passion you have for our field. So thank you for being here. And Lauren, stacking of methadone will be an ongoing discussion. We have been we do have new data that we will be able to just publish soon. And we know that the frequency of methadone as needed doses is also very important, in addition to the split AM and PM dose. And sometimes with postpartum, as you heard Dr. Shank pointing out, when we see people who have not had any prenatal care, who come to deliver at term, and you start right away to, just stabilize on methadone. Sometimes the methadone could be a little bit too strong. And one of the things that I personally try to do with patients is trying to educate them, to offer expectations. I call this educate, encourage, and empower, to allow people to have a voice and choices in their treatment while also boosting their own autonomy. And whenever I go to a patient's postpartum room, I usually ask the nurse, are you available to come with me? Because when we have a team-centered care and we give the patient voice to feel comfortable and safe to actually share with us what is the dose, and also educate her on possible sedation, respiratory rate, and how the methadone could impact in the hospital and also postpartum, it makes a big difference. So, I commend you for doing your best to stabilize people in the hospital. And actually in Washington State, now we are trying to come up with a pathway that will allow pregnant people, while they're still pregnant, to stay on the antepartum or medical floor to stabilize, not for 3 days, but for more days. And also for the group, I wanted to share with you that the postpartum compassion 5-day stay, we are working with our Washington senators, and we have a bill that will allow us to offer billing codes, not only for Washington State, but billing withdrawal management codes that are available across the U.S. for us to be able to stabilize postpartum people and not rushing to discharge them. And it's also our team effort to offer whole person care. So I see a lot of people nodding, and this group has been essential for all of us to work together as a team. And I'm looking forward for us to continue the conversation. Lauren, I hope that this helps.
Always. Thank you so, so much.
If there would be anything, that was great, Vanya. If there would be anything I add to that from like the scientific side, right? The issues with dose stacking for a pregnant person, right? We're doing this in a time of heightened metabolism and clearance. So the worries about dose stacking are a lot less, right? Because this person's going to be clearing it later. The other thing is, of course, doses are going to change in the outpatient world, right? The environment within which a drug is used contributes to the drug's effect, both its physiological and its behavioral effects. This is why I jumped into this field, was learning about that, that a drug can have multiple different effects in the same organism at the same time, depending on the environment that it's in, right? So a human in the hospital setting might need one dose, and when they go out and are exposed to all of the stimuli in their environment that may increase, it may trigger withdrawal signs because of compensatory physiological responses, or maybe they're going to go to a different environment that don't have those and maybe even have fewer. Of course, doses are going to change. They always do. And even among people who are stable in opioid treatment and opioid treatment program, their doses fluctuate. It's not always consistent. So a little bit of variability is going to happen. And again, sharing that with the people.
Hi, my name is Margie. I'm a nurse. I'm working in the state of Virginia. So I'm going to just give real quick feedback based on what our current addiction consult service does. And maybe this will be helpful when they have pregnant women that come in that want to have the rapid methadone titration. We've made it currently just kind of a condition of being admitted would be that, first of all, they are already engaged with some methadone clinic so that as soon as they're discharged, they have a clinic to go to. Then the other part of that is we ask our patients to talk to their provider at their methadone clinic to let them know, I'm going in, this is why. I know you all are doing the best you can, but on the outside, but it's not working for me, and they're going to monitor me 24/7, me and my baby, and I'm going to go faster. So when I come back to you, I will be on a higher dose so that they're aware. And then our addiction consult service provider, they literally reach out and talk to the provider of the methadone clinic before the patient is discharged. And in the beginning, we didn't do that. And we did have trouble. We had somebody that has a great methadone titration, left, got to the methadone clinic, and they were like, we're not giving you that. No way. Forget that dose. So since we put that in place, it's really tremendously helped. So I don't know. The other thing is that they do keep all the moms for 24 hours after the last dose, the dose that they think is good for the patient. They watch them for 24 full hours in the hospital before they leave, even when you talk about the dose stacking issue. So I don't know, it just seems to be working for our team pretty well. I'm in the outpatient clinic and I'm doing more of the navigation piece. But in Richmond, Virginia at VCU, where Dr. Martin works, we have a really great system underway. And part of that is our addiction consult service.
That's a great system you're talking about. And it reminded me of something I was thinking about earlier was, we're measuring withdrawal, right? We're probably doing COWS scores, right? And in that 24 hours later, should we be assessing something else? Not just the absence of opioid symptoms, but are there signs of impending issues that we should be evaluating? And then maybe that's the ticket. Say, hey, this person is showing a stability, not just a stability in absence of opioid withdrawal signs,
Right.
but
but they're not oversedated.
Exactly. Yeah.
But thank you for the talk.
Yeah. And we also keep patients for, like Daisy just said, keep patients for about 24 hours to evaluate that too. Yeah.
This is a great discussion. I love it. Any other questions that people have? I'll pause for a second.
I wanted to make a couple of more comments. Thinking about discharge and making sure that patients take their medications and their methadone, if we give dispensing home doses, is a good way for us to offer a phone visit or a telehealth encounter for the first 24 or 48 hours. Personally, it has really helped me continue connecting with the patient, making sure that they take their medications, and also being able to observe and monitor for possible sedation. For Lauren, I wanted to share with you that whenever I have a person on split methadone dose discharging to an OTP that I'm not sure how they will feel about the dose, I usually call the medical director and I talked with them before the patient discharges to offer any concerns, questions, and also to make sure that people know that this is a team effort. You can also reach out to us with any concerns, and it has been very helpful.
Just wanted to say that what Vanya is saying is extremely important. That communication is vital, because what we all don't understand, or many of us don't understand in the area of perinatal medicine, is that those individuals out there just dispensing the methadone and OTPs really don't have the knowledge that we all have about pregnancy and the newborns. And they don't understand why we would do the things we do. So they have to understand that. I found that to be true also with some of the administrative people that from the state who, when I wanted to raise the dose of methadone, uh, it would be an argument, and I'd literally threaten them with the fact that, yeah, the death of that woman will be on you, and some horrible things like that, just because I couldn't get through to these people because of their cognitive inabilities. But communication is so important, and treating these patients as if they have any other kind of disease, whether it's heart disease or lung disease or whatever, is important. And people out there don't realize that. They don't realize that addiction is a disease and that they deserve to be treated like any other human being that has a medical illness. Thank you for letting me uh, comment. So as I said before, I'm just so happy to see what's going on in the research area. As I gave the first dose in the 70s, I was 32 years old. Now I'm 88, and it's amazing how much has happened over those years. And I'm so thankful for it, and it continues. And as Dennis says, look, we've got all these things to do. So the field is so interesting to all of us because we have a lot to do to improve it even more.
Thank you so much, Loretta, for those words. And actually, that is an excellent place for us to end because we are at time. So thank you all so much for coming, and thank you, Dennis, for your presentation, and thank you everyone for this lovely discussion in the setting of advocacy and also patient-centeredness and how we can continue to use evidence to inform care improvements. And thank you all again for coming, and I will see you for our next journal club, which will be July 28th in the afternoon sometime. Okay, thank you. Bye.
Thank you. Bye.
Bye.
Bye.